Hello everyone, welcome to Anesthesia School. I'm Ruslan. Today we are here with our second English language video. We are going to discuss brain death. Actually, the term brainstem death would be more accurate because the anatomical structure we examine and the diagnosis that is ultimately made is essentially the brainstem itself. The newer terminology which appears in many recent sources is diagnosis of death using neurological criteria. This is an extremely important part of organ transplantation and, in fact, represents its very first step. As anesthesiologists or intensivists, we must be familiar with the topic as well as with the legislation of the country we practice in. It is also important to remember that these regulations are updated periodically. For example, when I was a student, physicians from 4 different specialties had to establish the diagnosis, which made the process extremely difficult. If I remember correctly, we were one of only 2 countries in the world that were dependent on 4 different physicians. Nowadays in Türkiye, physicians from only 2 specialties are sufficient. One must be an anesthesiologist or intensivist, and the other must be either a neurologist or a neurosurgeon. In pediatric patients, pediatric intensive care specialists and pediatric neurologists are involved as well. The regulations are highly detailed and, as I mentioned, are continuously updated. Therefore, I will also add several laws and regulations currently valid in our country in the description section below. I hope you enjoy it. Have a nice listening. Nowadays, this topic may also appear in various sources as brain death examination, or as I mentioned before, diagnosis of death using neurological criteria. Fundamentally, this subject can be approached as an anatomy question, but once we incorporate the functions of the cranial nerves, it also requires a good understanding of the physiology. In particular, the neurological basis of the cranial nerve examinations we perform must be understood. Looking at the definition, it can be described as the irreversible loss of consciousness and respiratory function. Before making the diagnosis, certain prerequisites must absolutely be fulfilled. First, there must be a definite diagnosis explaining the brain injury. The patient must be in apneic coma with a Glasgow Coma Scale score of 3. Normothermia must be present. In fact, a temperature of 35 Celsius or above is generally sufficient. Normocapnia should also be present. There must be no circulatory failure severe enough to impair cerebral perfusion and no metabolic or endocrine disorder that can cause coma. The effects of sedative agents or neuromuscular blockers must be shown to have resolved. For sedatives, this is generally assessed according to pharmacokinetic properties such as approximately 4 half-life times. Whereas for neuromuscular blockers, we usually rely on neuromuscular monitoring devices. Of course, context-sensitive half-time must be considered in prolonged infusions, and toxicological studies may be required in cases of poisoning, but we will not go into those details here. Essentially, we can talk about 3 categories of tests in the diagnosis of brain death: cranial nerve reflexes, the apnea test, and ancillary tests. The first 2 are generally recommended to be repeated twice, although as I mentioned, guidelines and regulations may vary. Let's look at the cranial nerve examinations. As we know, there are 12 pairs of cranial nerves, however, we only examine some of them. For the second nerve, the optic nerve, we assess the direct and consensual or indirect light reflexes. For the fifth nerve, the trigeminal nerve, we examine the corneal reflex. For the seventh nerve, the facial nerve, we evaluate the response to painful stimulus applied to the supra or infraorbital notches. For the eighth nerve, the vestibulocochlear nerve, we perform the caloric test using ice-cold water irrigation into the ear. For the ninth and 10th nerves, the glossopharyngeal and vagus nerves, we assess responses to stimulus of the pharynx, larynx, and trachea. Actually, there are also the 13th and 14th cranial nerves. The 13th one, known as the nervus terminalis, is also involved in the regulation of reproductive behavior, whereas the 14th nerve, known as the nervus intermedius, is associated with the function of tasks like lacrimation and salivation. However, knowing these two nerves is certainly not mandatory. It may simply be useful for those who want to show off a little. Anyway, after these examinations, the apnea test is of course performed. The purpose of this test is to increase carbon dioxide levels and observe whether a respiratory drive develops or not. To prevent hypoxia, the patient is first ventilated with 100% oxygen for approximately 10 minutes, aiming for an arterial oxygen tension above 200 mm mercury. It may even be useful to confirm this with an arterial blood gas analysis, although this is not absolutely necessary. Then apneic oxygenation is provided through a thin catheter or one end of the nasal cannula, which is inserted in the endotracheal tube and put above the carina. You should be careful not to obstruct the tube, otherwise barotrauma may occur. Under normal metabolic conditions, carbon dioxide is expected to rise by approximately 3 to 6 mm mercury per minute. Our target is either a carbon dioxide above 60 or an increase in carbon dioxide for 20 from the baseline. This 20 increase is particularly important in patients with chronically elevated baseline carbon dioxide values, for whom using 60 mm mercury as a reference would be entirely inappropriate. In its 23 guideline, the American Academy of Neurology also states that the pH should fall below 730. I added this source in the description section, and you can also see that on the screen below. Looking at the rise in carbon dioxide, a simple mathematical calculation suggests that this test is going to last for about 7 minutes. If hypoxia or hypotension develops or any cardiac arrhythmia develops during the test, it must be terminated. Naturally, the test must also be stopped if any respiratory effort is observed, in which case the test is considered negative. This is the guideline I just mentioned, the American Academy of Neurology 2023 guidelines. It was developed in collaboration with the American Academy of Pediatrics, the Child Neurology Society, and the Society of Critical Care Medicine. It covers both adult and pediatric patients. When we look at its contents, we see that the authors compared it with the guidelines they had previously published in 2010 and 11. They discussed new recommendations, differences from the previous guidelines, and so on. It is extremely detailed. For example, it thoroughly discusses the prerequisites required before establishing the diagnosis. It also describes the details of the physical examination, including the qualifications and number of examiners, as well as the content of the examination itself. The apnea test is discussed in details also, and of course the ancillary tests are covered as well. It is important to know that there are certain conditions that can mimic brain death, and these must be kept in mind in differential diagnosis. Examples include severe Guillain-Barré syndrome, Miller-Fisher syndrome, brainstem encephalitis, which is temporary, and ventral pontine infraction leading to Lactin syndrome. These conditions must be excluded and additional tests should be used when necessary. There are also confirmatory tests. Examples include EEG, auditory, visual, and somatosensory evoked potentials, CT angio, and MR angio. However, these are no longer recommended in the latest guideline, which I mentioned in the previous slides, even though they are still mentioned in some sources. Instead, cerebral angiography, radionuclide cerebral blood flow scanning, and transcranial Doppler ultrasonography are recommended. By the way, the last one, the TCD, is recommended for adults only. Of course, it should not be forgotten that none of these tests are absolutely mandatory. A proper physical examination and a well-conducted apnea test are sufficient for the diagnosis. Finally, let's briefly discuss the management of potential organ donors. These patients are classified as ASA6. One must wonder whether anesthesia is necessary for a brain that is already dead. But we actually take the advantage of important non-anesthetic effects of anesthetic agents here. The autonomic, metabolic, and endocrine systems of these patients may still be functioning remarkably well. In hemodynamic management, adequate perfusion must be maintained. Euvolemia should be ensured, and vasopressor or inotropic support should be provided when necessary, with vasopressin being the first-line agent. Diabetes insipidus is common in this patient group, and they may lose a large amount of fluids. Direct arterial blood pressure monitoring is recommended, and pulmonary arterial catheterization may be used when necessary. One should remember that spinal reflex arcs remain intact, and therefore a pressure response may occur in response to surgical stimulation. Regarding respiratory management, the main goal is adequate oxygenation of the patient, and lung protective ventilation strategies are recommended here. Since hypothalamic dysfunction is common in these patients, hypothermia is also frequent and active warming may be required. As for endocrine and metabolic management, pituitary dysfunction may occur and desmopressin administration may become necessary. Depending on the situation, thyroid hormone and glucocorticoid supplementation may also be required. Insulin therapy may be needed to maintain normal glycemia. Serum electrolytes should be kept within normal range as much as possible. As we mentioned earlier, autonomic and spinal motor reflexes remain preserved. Extremity and trunk movements may occur during surgery. Therefore, neuromuscular blocking agents should be administered. Volatile anesthetic agents may also suppress these reflexes to some extent. In addition, these agents have some ischemic preconditioning effects, the similar ones that we see in the cardiac surgery, which can potentially prolong the cold ischemia time of transplanted organs. Generally speaking, these times are approximately 4 to 6 hours for the heart and lungs, 6 to 8 hours for the small intestine, and around 12 hours for the liver and pancreas, and up to 36 hours for the kidneys. These values are different, may vary in different references, and are actually dependent on many factors. This is simply to give you a brief and general idea about this. It is not today's topic. Maybe we will discuss it in another video. That's all for today. Thank you for listening. See you in the next video. Goodbye for now and have a wonderful rest of your day.